Hello, everyone, and welcome. We're just going to hold here for a couple of seconds just to let everybody join in wherever you're coming from across Canada or outside. Thank you so much for joining us today. We're joined by some lovely speakers on this cold winter day. Grab a blanket, some hot chocolate, some tea, some coffee, whatever you need, and we're going to get started very soon. We're just going to hold a couple more seconds here. Okay, good afternoon, everyone, and welcome. My name is Kat, and I am DWDC's program specialist. Today, I'm joined by my colleagues Amanda and Taylor. We would like to begin by acknowledging that the land on which we gather here today is the traditional territory of the Wendat, the Anishinaabe, Haudenosaunee, Métis, and the Mississaugas of the Credit First Nation. These nations continue to experience ongoing colonization and displacement. Today, Toronto is covered under Treaty 13 and the Williams Treaties. Dying with Dignity Canada is also mindful of broken treaties that occurred across Turtle Island and recognize our responsibilities as treaty people to engage in reconciliation with all peoples across this land. I'm thrilled to welcome you today to our next session of Regional Spotlight, a series which aims to provide you with more information on how to successfully navigate MAID and your end-of-life care in every province. For today's session, we'll be focusing on the province of British Columbia. And before I welcome today's speakers, I'd like to go over a few housekeeping items. Everyone on the call today is muted. However, there will be opportunities to submit questions. To do so, please type your questions into the question bar on the Zoom side panel, and we will read it out for you at the very end. Please try to keep your questions as concise and clear as possible. While we're going to try to get to as many audience questions as possible today, unfortunately, we may not get to everyone. If you have any outstanding questions or questions that are personal in nature, please email us at support@dyingwithdignity.ca, and we will follow up with you there. This session is being recorded. There will be a post-webinar survey that will pop up on your screen after the webinar, and we will give you the opportunity to share your feedback there. And now to introduce today's speakers. Dr. Adam Sandell is a MAID assessor and provider in BC and medical advisor to the BC Ministry of Health's MAID Oversight Unit. He's a GP, ER doctor, and medical team lead at Healthsick Hospital in Bella Bella and teaches medical students and residents at the University of British Columbia. Originally from the UK, where he worked as a human rights barrister, which is a trial lawyer, alongside his work as a doctor, he represented clients in the UK Supreme Court and Court of Appeal of England and Wales in cases seeking to recognize a right to MAID in the UK. He's currently writing a book and regular email about serenity and success doing work that matters, and you can visit him online at www.adamsandell.com. Dawn Versluis is a nurse practitioner, MAID provider, and an assistant teaching professor in the University of Victoria's School of Nursing program. Dawn began his career as a registered nurse in the emergency department and regional trauma center in Ontario before obtaining his Master of Science and Nurse Practitioner certificate. He joined Niagara Health as an internal medicine nurse practitioner and returned to McMaster once again as an instructor in the nurse practitioner program from 2017 to 2020. In 2020, Dawn moved to British Columbia, where he remains an active clinician and instructor. Dawn was one of Canada's first nurse practitioners to provide medical assistance in dying and has been recognized for his work with MAID with several awards, including Niagara Health's President's Award of Excellence and the Advanced Practice Nursing Award of Excellence. Thank you so much to our speakers for joining us today. And now I'm going to pass it on to Amanda to get us started with the interview.
All right. Thank you so much, Kat. And thank you so much, Dawn and Adam, for joining us today. We're going to go ahead and get started with the interview questions. So we'll kind of go in a round just because we have two speakers. So anybody who'd like to jump in first with this question, please feel free. So we'll start off with what inspired you to enter this field?
I will take it, sure. Um, Thanks, Amanda. Before we get started, I'll just make a quick note that I'm on the CAM app, which is the National Association for Assessors and Providers. I'm not representing them today, though. But what got me into the MAID practice to begin with? It's not really something I ever thought about until someone asked me about it. And so really, it was just that first person who asked me about it, and I went on and looked into it. And we didn't really have any policy or procedure on what to do about it. And so at that time, Niagara Health was quite supportive, and they totally supported me in kind of expanding my practice to incorporate that. And so really, it was just that one first person who I was talking with and asked me about it.
Yeah, absolutely.
Hmm.
One patient makes all the difference, doesn't it?
Yeah, yeah.
Yeah. And Adam, same question for you.
Yeah, I similarly got into it kind of by accident. I've had a very strange career. I moved to Canada 5 years ago, and before that was a GP in the UK, where MAID is not currently legal. But I parallel to that worked as a human rights lawyer, and inevitably got involved in cases that had a medical twist to them of one sort or another. Was asked to become involved in litigation in the UK that was seeking to do what Canada had successfully done, which was to use human rights litigation to try and recognise a human right to medical assistance in dying. So spent quite a lot of my legal career working on that, unsuccessfully, and then moved to Canada, and I guess unsurprisingly was approached sometime after moving here, to be asked whether I might be willing to be involved. And I guess I kind of felt a little bit of a responsibility to put my money where my mouth was, or at least to dip into that as a doctor. And it's very different from the rest of the work that I do, and something that I find interesting.
All right. Thank you so much. Next question, Adam, we'll start with you this time. In your experience, is death something that is commonly or openly talked about within your community, in the community that you practice in?
So, I mean, it's a really interesting question, and I think the answer to that depends very much on the community that you're talking about. My main job is on a reserve with an Indigenous population, um, and conversations about death are very different there and heavily informed by but both by that particular nation's cultural history, and also by people's history of trauma inflicted by people who look a lot and sound a lot like me. So from the perspective of MAID, I think most people who are carrying out assessments for and providing MAID find that they encounter very, very few requests for medical assistance in dying from Indigenous people. If I look at kind of my own community, of settler, white collar, people who are used to having substantially more control over their destinies and over the ways in which their lives unfold. It seems to me that conversations about death are becoming ever more comfortable and routine. And I still have parents who are alive but in their 80s, and this is sort of common conversation, is making plans and figuring out how things can work for the best. And I welcome that.
Yeah, absolutely. Thank you so much. Dawn, same question for you. In your experience, is death something that is commonly or openly spoken about within the community?
I think so. I have a few similarly to Adam, actually. I think it depends on the community. I think in my own family, until it was relevant, not so much. Like when we lost someone in our family, we certainly talked about it then. And I lost my grandparents when I was younger. And so we did talk about it. I think there's also a bit of a bias I had because lots changed when I moved to BC. I moved out here right at the start of lockdown. So there was that confounding variable that changed a lot of things, and also with my MAID work. So my experience in Ontario is that it was sometimes talked about. As I became an NP, more so because I dealt with frail elderly in my internal medicine role there. Um, when I moved to BC, I definitely found people more comfortable in talking about it, but I think that was around 2020, so things were changing. And so I don't know necessarily if it's BC or just the time that caused that shift. I think over time, I mean, everyone talks to me about death and dying now, and just given it's such a core part of my role. And so I'm quite comfortable with it now. And so I think in my experience, more so in Ontario and more so in recent years, people are much more common to talk about it.
Yeah. Okay. Thank you both. Next question. Dawn, we'll start with you this time.
Sure.
You kind of already touched on the regional differences between your
Mhm.
experiences in Ontario and your experiences in BC, and a little bit about the impact as well of perhaps the pandemic adding a new element in there. But, if I'm wondering if there's anything else you want to add about how discussions about death or discussions about dying have changed over the past 5 to 10 years, both kind of in your role as a healthcare provider, but also sort of as an observer of patients and their
Mhm.
families.
So I think it's much more commonplace in conversation lately. I think in my experience, I think BC is a very pragmatic population. And so, especially here on Vancouver Island, it's quite an older population. And so it is more a topic of conversation here. I think also in my experience, I have found religion to be both a barrier and facilitator. And I think that that has shifted quite a bit over the past 5 to 10 years. I think people who are Catholic are becoming more comfortable about talking about it. At least that's been my experience. And I have an example in Ontario. I did get some hate mail from a Catholic group right at the beginning when someone thanked me in an obituary. And so that was pretty, I don't know, disruptive to my
Jarring.
practice a little bit. It really made me think about safety because the mail was anonymous, and so it's a little bit scary. But that was kind of a blip in time. Like that never persisted. And especially now, even patients who choose MAID and are Catholic, I think that that has become much more comfortable for that group. Again, at least in my experience. Yeah,
Yeah.
so I think that discussion is becoming much more open about it. And I think that's important because I think historically in North America, we haven't done a great job about talking about death and dying until someone can't kind of engage in that conversation when it relates to them anymore. So I think that is a positive.
Yeah, absolutely. Adam, same question for you. How, if at all, have discussions surrounding death and dying changed over the past 5 to 10 years? And I know that, you've not only just practiced in Bella Bella, so it might be interesting to hear a bit about the UK perspective when you still practice there, as well as the Canadian perspective.
Yeah, and again, I think this is one of those questions, the answer to which depends very much on the exact community that you're speaking of. It's not, it's not just Canada or BC or the
Hmm.
UK, but particular cultural groups, within those communities. But I would echo what Don says, and I also am interested in and agree with the point that he makes about the interesting relationship between religion and the sorts of conversations that people are able to have about death and dying and potentially medical assistance. I think that's exactly right. That I think on the whole, this is something we are becoming more comfortable talking about. I think there are some groups that have become very comfortable talking about it. The kind of stereotypically white, university educated, middle class, progressive, coastal BC stereotype kind of person. A class into which I would accept that I fall myself, and other, and especially ethnic minority groups. I think it is. I mean, I'm no expert on this, but it is very, very different amongst indigenous peoples for all sorts of reasons. I find Chinese communities of whom we have substantial numbers in the lower mainland, on the whole comfortable about talking about it. Other communities less comfortable talking about it. But it feels to me as though, because all we're talking about is talking, that things are slowly moving in the right direction, and that's a very positive thing.
Yeah. All right. Thank you both. Next question. Let's talk a little bit now more specifically about medical assistance in dying. And Adam, we'll start with you this time. What are some common misconceptions about the process for medical assistance in dying?
Yeah, I think there are a few that I come across, and one that it's easy for those of us who are involved in it to forget about is the number of people who are still not aware that it is an option. And I suspect all of us and everyone on this call knows and has a bit of information about it, but there are still, I think, quite a lot of people in Canada who are simply unaware that this is something that is available to them, and that concerns me a bit, because I suspect there are people who would want to exercise that option who may not know that it is there, or just may not think that it is for them. Amongst the patients and families that I meet through my MAID work, I think a lot of people think that it will be more complicated than in fact the process is. It seems to me that Canada has struck quite a careful balance in terms of adequate safeguards, and at the same time not making the process unduly onerous. I just as an aside mention that the process that's now being considered in the UK, although this hasn't yet been legislated, would involve having to go to court, and a judge making a final decision. And I think Canada has been wise to steer away from that. So I think people are often kind of pleasantly surprised that this needn't be a particularly hard process, especially for people who are frail and very close to the ends of their lives, and simply wouldn't be able to go through an onerous assessment process. And then I think the other misconceptions that I come across from time to time are that anyone can get MAID, and that it's easy. So kind of the opposite point from the point that I was just making. And there are some things that are simply flagrantly untrue that are spread by conspiracy theorists. But I actually don't think there are very many of those. We all get our knickers in a twist about them a bit, but I actually don't think there are, I'm not too concerned about those misconceptions. But I think that the misconception that anyone can rock up and ask for MAID, and that it's completely straightforward, is actually fundamentally wrong. Remember, the process involves two independent assessments, carried out using quite complex set of criteria that people need to fulfill, each of which requires a certain amount of thought to ensure that people meet those criteria. I do, just speaking from my personal experience, I've seen it as a huge success when someone has approached me for MAID, and we've gone through the assessment process and started to talk about alternatives, which is an essential part of any MAID assessment. And the outcome of that conversation is that my patient has decided that MAID is not for them at that moment, and that there are other things that they would like to pursue that they haven't pursued, and I've helped them pursue those things. The other experience that I have with really difficult MAID cases, the sort that that really challenge us, is sleepless nights, kind of worrying about how to do the best for the patient and keep things, to ensure that the law is complied for, and that I do the very best for patient in extraordinarily difficult circumstances. So I think that's another misconception, that anyone can pick up a phone and make a phone call and be killed without having to go through a fairly rigorous assessment process. Yeah.
Yeah, thank you. Dawn, same question for you. What are some common misconceptions about the process for medical assistance in dying in your experience with patients?
I think specific to me, so although I have a doctorate, I'm not a physician, I'm a nurse practitioner. And so I found one was that only physicians can provide medical assistance in dying. And so I think that's part of my kind of general mission, is to advocate for the nurse practitioner role. I think I think over time the perception has been much corrected. Like there's a lot more quality information out there now, and so people are better informed for that reason. I think there is still some talk about how MAID providers are killing or murdering people, and that is not true. There's a pretty rigorous set of safeguards to limit or prevent that from happening. But then there are also stories in the news of people in very socially disadvantaged states, and that they receive medical assistance in dying for the suffering that's related to their social circumstance. And that is untrue. I think in specific cases, providers, of course, can't comment because of confidentiality. And so there's never a rebuttal to those arguments. And so they persist a little bit. But I think the truth about social disadvantage is that those things are intertwined and you can't separate them. And so someone with MS can be suffering horribly, but someone with MS and without housing suffers more. And they could both be eligible for medical assistance in dying. And so it is kind of teasing apart the nuances a little bit. But I think people are becoming more critical, and there's been better information coming out, including webinars like this that help clarify those misconceptions.
Yeah, absolutely. Thank you both so much. Next question. Dawn, let's start with you. Have
Sure.
you ever received feedback from individuals that experienced a MAID death about what they found helpful or unhelpful as they navigated their grief? As you know, a MAID death is a bit different from perhaps what you'd call a natural death, in that there's an anticipated date, there's a specific process for the dying experience. And, you know, the anticipatory grief is obviously no different, but a bit different just because of the nature of the death. So I'm curious what your thoughts are on that.
Sure. I think certainly I've received feedback over the years. I've been kind of in the MAID world since 2016 now, so it's a little bit distance, kind of my experience at the beginning compared to now, but I can certainly say I have a much more established process now. And so I find some of the things people tell me that are most helpful is discussing things ahead of time and going over what some kind of a, I mean, there's a small chance of certain things happening, like snores or one gasp. And I think mentioning things like that ahead of time alleviates a lot of anxiety. They usually don't happen, but if I don't mention it and it does happen, it can provoke anxiety. But when I mention it and it doesn't happen most of the time, people feel better being reassured ahead of time about what to expect. I think that briefing is really invaluable to be able to, like, having a conversation ahead of time to prepare them, specific to physiologic responses, and then also about kind of planning afterwards. I think there is definitely an opportunity of what I call productive grieving, where you can apologize or say the thing you wanted to say or give the thing you wanted to, which we don't necessarily get in the natural deaths, as you called it. And so I think that having that conversation about how to kind of optimize the experience ahead of time can be quite helpful.
Yeah, absolutely. Thank you. Adam, same question for you. Any feedback from individuals that have experienced a MAID death, and, you know, what was helpful or unhelpful for them as they navigated their grief?
Yeah, I would definitely endorse what Don says. I think that's right. I think there's, you know, we're looking at a self-selected population with people who go through MAID, because they tend to be people who are more used to exercising control over their lives. It's, you know, again, I'll say it's kind of people like me who like to be in control of things. And 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 I think often actually people, you know, grief following MAID. My sense, I have no data for this, and maybe there is data that I'm not aware of. My sense is that grief following a MAID death tends to be attenuated compared to grief after many other deaths. It tends to be, it tends to be easier to manage because there is some planning, because conversations have gone on, and because it is a selected population of people who may just because of their approach do a bit better, or have the resources to do better. I think good communication between families beforehand and ensuring that things that haven't been said and need to be said are said, and the worries that people have or concerns that people have are aired, makes a big difference. I've certainly had that feedback. Um, uh, um, and another point that I quite often find myself making is not excessively protecting children and teenagers from what's going on. I think our instincts often are not to tell kids the whole story, or for them not to be present at the MAID death. And in fact, like all of us, children's imagination is much worse than reality. And in fact, even from quite a young age, giving children and teenagers the opportunity to ask questions and to be there, to be part of the assessment process, to be part there, present while someone is receiving MAID, almost invariably, in my experience, has been a positive experience for them and for everyone else involved. And I guess I'd say the same thing about family members who have a problem with MAID. My experience has been, let's just let's have that conversation. If my patient is happy for them to be part of the assessment, then that feels good to me, because they can at least see what's going on and have their feelings taken into account, and have their voice heard. So I guess the simple answer is openness and communication. There's also a couple of resources that I think people have found useful in navigating grief, and I think we're going to come back to that maybe later on in this session, so I can speak to them at that point if that's helpful.
Great. Otherwise, if I happen to skip over it, feel free to stop me so that we can list
Okay.
those out. But thank you. Don, before we move on, I just wanted to check. I saw you nodding your head with some of the additional points Adam made. I just wanted to see if you had any further comments before we move on.
I don't think so. I agree with them. I think especially about minors, like I find them I don't deal a lot with pediatric populations in my general work, but I've been incredibly impressed with how resilient and reasonable they turn out being in MAID provision. So I think it truly is up to the family to sort out whether that's appropriate for their specific context. But I've been really surprised by how well they handle it.
Yeah, absolutely. Okay, next question. Let's go ahead and start with Dawn. So, at times on or leading up to the day where MAID is actually provided to the patient, that patient and their loved ones may choose to ceremonialize the occasion. So, it might be something like playing their favorite music, or sitting around in quiet prayer, or having, a wake, a living wake, excuse me, that sort of thing. I'm wondering if, in your experience as a MAID clinician, have there been any of those moments with a patient of yours, or if a story stands out to you?
A specific story, I'm not sure I can pull up right at the moment, but I think absolutely that's definitely the case. I'm not a very spiritual person myself. However, in Ontario, I worked very closely with spiritual care, and I was pretty amazed by how productive that experience can be for some people, like the meaning making of it. And I alluded to that a little bit earlier with like saying the thing or apologizing or giving the thing. And same with songs and poems. Like people get out of that what they put into it, really. And I find it can be very helpful for people coping. I think it's in MAID specifically, it's a rare opportunity when we can very specifically schedule death, which we don't ever do otherwise. And so I think there is an abundant opportunity to make those meaningful moments using some of those strategies to ceremonialize it.
Yeah, thank you. I like the way you said scheduled death. I
Yeah.
think that's a great way of framing it. Adam, same question. Any stories or patients kind of that stick out of mind here about ceremonializing that day or leading up to their provision?
Yeah, it's interesting. I'm actually struck by how few people want additional ceremony, and how many it's almost the ordinariness of the process that seems meaningful in some way. And again, maybe this is something about the sorts of people to whom MAID appeals. I mean, I've been very moved at MAID deaths where I've been present, where there's been, huge numbers of family around. Um, I've also been moved when when there's just been one person, maybe a spouse, and the whole thing isn't, there's been no concern about ceremony or music or anything else, and yet there is something, it is a huge thing, isn't it, to die? It's the only other thing we do in our life like that is being born, and we don't remember that. And there is something almost always in my experience just extraordinarily tender about the moment. I think because what we are doing, I hope, is inherently compassionate, and because the people who are there generally are there out of love. And there is just this kind of tenderness is the word that I would choose for it. That no matter how you decide to, it's a bit like birth plans, isn't it? When people are making their birth plans, they decide exactly which Mozart piano concerto is going to be playing at each stage of labor. But actually, in the heat of the moment, it never works out like that, and all hell breaks loose, and then you have the baby,
Yeah.
and now you're dealing with other problems. And in a way, I think MAID is there's something so immense about what is going on that for many people that's almost all you need. And I have never walked away from a MAID death without feeling moved by the experience.
Yeah. And I think it's interesting that, Dawn sort of brings up the multiple types of ceremonies or acts that somebody might do to ceremonialize. And then on the flip side, you say that actually it's quite an ordinary procedure, or there's no pomp and circumstance, and yet in all of those circumstances, the patient gets to choose the death that they want, and I think that's really what
Yeah.
underpins MAID, right? Is that whether you want it to be something with pomp and circumstance, or if it's just going to be something very simple and solemn, I think it's wonderful that everybody gets to have that choice and that providers are supportive of it. So
One thing, I mean, one thing is maybe worth mentioning that I didn't learn immediately, and in fact learnt from something said to me by a more experienced MAID provider, was my role as the a clinician providing MAID in choreography. People like someone to say what's going on and to explain what's happening next and to take a little bit of responsibility, and it's quite a delicate balance to strike, because actually none of this is about me. In a sense, I'm the least important person there with a technical job to do, but it's a little bit more than technical, because there is kind of communication, making sure that everyone understands and feels supported in the right way at the right moment. And that's been interesting for me to learn, because I think I've been able to do a little bit better a job for my patients and their families and loved ones once I realized that was something I needed actively to think about.
yeah. All right, thank you. Let's go to next question. So we're going to move a little bit from the topic of medical assistance in dying, and talk a little bit more about grief, bereavement, and what kind of resources might be available in BC. So Dawn, let's go ahead and start with you this time. Do you personally ever experience grief in your work? How do you navigate this, particularly after the death of a patient, for example?
I think this is a great question. Do I experience grief? I'd say yes. But it's very different than in other aspects, I think. Um, I think Adam made a good point saying that your very technical role, but it's technical plus. So your emotional support, your logistics, your clinical, technical, yes, like medication administration, I mean, you definitely giving them in the correct order in that, but also you're looking around the room as someone like gray and leaning against the wall, like really not well because it's so intense. And so there is that I would say grief for me presents more as fatigue, because you're kind of on being a MAID provider. So you're kind of observing everything. And I think that also helps me be kind of an anchor for the room, because people do look to you, like they kind of like the saying of look to the flight attendant's eyes. Like people, I find, yes, they're having a meaningful moment with their loved one who's dying, but I do find there's a lot of eyes on me also. And so you do have to kind of wear that mask of calmness in that. And so for me, the grief mostly presents as fatigue. I find that for me, what's really helpful for dealing with that afterwards, I'm not too social after a MAID provision usually, but I do find having a community of practice available to discuss and debrief cases, especially challenging ones, really helpful, because this type of work isn't something I can go to my friends and say, you'll never guess what happened to me at work today. You kind of need that special or that unique group of people who have had the similar experience that you can talk to frankly about that. And we have some resources for that. I think this is a good opportunity to plug. Adam has a podcast, actually, great work is what it's called. And I find it's not specific to MAID, but there are a lot of practical strategies in there about how to kind of cope with things in your work. And so I think having that community of practice and having some good resources for grounding and to kind of decompress is very helpful.
Yeah, absolutely. Thank you. Adam, same question for you. Do you experience grief in your work, and how do you navigate this?
Yeah, I mean, I agree. It's an interesting question, and thank you for the plug, Don. I do experience grief in my work, or at least sadness. I mean, I think, as a healthcare provider working at the sharp end, you experience a fair bit of death, and that's one of the things you learn in early years is how you navigate that. Um, I think I experience more of it in in association with deaths of patients who aren't MAID patients, particularly older people, because most people die when they're old, whom I've got to know over a prolonged period of time and become fond of. And I think I experience the same sadness and sense of loss that we do in any context when you've got to know someone and become fond of them and then they die. And occasionally, and in fact, it's funny the timing. Last week, one of my emergency room patients, 20 years younger than me, died, and no one 20 years younger than me should be dying. I'd only just met him in the emergency room, but I'm still processing that because it was terrible. In MAID, in respect of medical assistance in dying, I think it's more of an issue when I've got to know patients over a prolonged period of time, which means the more complex cases, the sort of neurodegenerative conditions, where I've got to know people over a prolonged period of time. And again, I generally like people, and you become, you build a connection and you become fond of them, so yes. But I think there is also something about doing this professionally that does protect us if we're looking after ourselves properly, because it is a part of the job, and I would never compare my feelings about my work to the feelings of patients and their families who are for real dealing with what it is that they are dealing with, because it is a great privilege for me to do this fascinating work that I get to do, and I am happy to have some negative emotions as well as all of the positive emotions that go with being able to do what I do with my working life.
Yeah, absolutely. Well, thank you both. So now we're going to talk about resources, as Adam had kindly pointed out for us before. So Adam, let's start with you this time. Are there any resources that you would recommend for people experiencing grief, specifically in the province of BC, whether that's related to medical assistance and dying, or just somebody that is grieving the loss of somebody who has died?
Yeah, there are that I'm aware of that are worth mentioning. The one that I have some experience of, just because I've heard positive things from patients and families, is an organization called Bridge C14. C14 being the bill that gave rise to medical assistance in dying in Canada. Bridge C14 is a Canadian-wide organization. It's not based in BC. And it supports everyone involved in the MAID process. So patients, family members, friends who have a problem with MAID, and are horrified that their friend is seeking to go through it. Whoever you are and wherever you're coming from, Bridge is an organization that supports people, and they offer all kinds of things, including support groups, and they've got advice online and people you can talk to, and a whole bunch of things, and very much kind of support for people experiencing grief following MAID death. So that's something that I signpost most, if not all, of my patients and their families too. The other organization that is, but I don't know anything about it, I just am aware that it exists, is an organization called the BC, the British Columbia Bereavement Helpline, which is exactly what it says on the tin, as far as I'm aware. And I just kind of know that it's there specifically for people in BC who are experiencing grief. So those two organizations, Bridge C14 and the BC Bereavement Helpline, we don't need to give addresses anymore or phone numbers, do we? Because we all know how to find stuff on the internet, and they're both easy to find.
Yeah, fantastic. And for the audience members, we can always include that in our follow-up email afterwards when we post the recording. So thank you for that, Adam. Dawn, same question for you. Any resources that you'd recommend for people experiencing grief in BC, or resources you kind of always go to when speaking with patients and their families?
So I think this is another interesting question. I think there is a bit of a gap for supports like that for families. I do find that the whole team kind of evaporates a little bit after the person has died. And so, I mean, there is room for improvement there, but there are a number of good bereavement support groups. So Dying with Dignity has some resources. MAID Family Support Society, another good one. Similar to how I mentioned earlier about how it's helpful to have a community of practice, so a community of MAID providers to talk to about these things. MAID Family Support Society has peer supporters, so people who have had family members that have gone through MAID, because I think it is, well, maybe less so a unique experience now that we're 8-9 years into it, but especially at the beginning, very, very helpful to be able to talk to someone with a similar experience. I think also specific to BC, all of the health authority websites tend to have some good resources for kind of help navigating the MAID process altogether, and also the support afterwards. And so there are a number available.
Yeah, but before we move on, I'd just like to touch on one thing that you mentioned about sort of the gap in resources and how that team of encircled support sort of evaporates after a patient dies. I'm wondering if you can share a bit with the audience about, explore that a bit and break that down so that, somebody that might be a patient that's sort of having a life-limiting illness, what sort of things should a loved one start to expect in terms of that support evaporating, and how could they kind of circumvent that so that they have support after that loss?
I think, I mean, it's part of kind of my package now. So I have kind of a flow sheet of all of the things I want to do. And so on that is to provide some of the resources. And what I mean by evaporating is the communication between the MAID team, like the coordination team, myself, and the person, especially leading right up. So in the day or two before, there's a lot of back and forth communication. And then after the provision, my role is somewhat done. Like I have reporting requirements to do, but then it's on to the next case a lot of the time. It is improving. Like there are initiatives. I know within my own health authority, Island Health, we do have social work who can help with that. We have spiritual care. And then we're also starting a volunteer program to follow up with people after the fact, but that's still in development. And so that's kind of more so what I mean is myself and the coordination team specifically, who do all of the liaising and coordination. Once it's done, our role is quite limited, and it's, unless there's an issue, I tend not to hear much from the family after that. And so that's kind of what I meant by that.
Thank you so much. All right, next question. Let's start with you, Adam. Are death doulas commonly contacted for supporting individuals that are going through the death process, dying process, grieving, or healing in your area? Have you ever worked with a patient that had a death doula, or have you ever reached out to a death doula for their support with a patient?
Literally never in my experience, so I'm not sure there's anything terribly informative I can say about that. But I think Don is more experienced than me, so he may have he may have more to share.
Sure. So I've had one experience working with a death doula specifically. I had some reservations. So a few reservations I had were it's an unregulated profession. There's not really a standardized curriculum for them. And so most people can call themselves a death doula. It is quite costly. However, I think it does fill a gap that exists, as I mentioned, about the team kind of not being involved after the fact. That's not the case with a death doula. I think it essentially is, especially people with very small social networks. I also see patients on a lot of the small islands just off the coast of southern BC. And so those small communities, I find without huge social networks, that's the kind of case that I experienced. I found it extremely helpful to have someone there and to help facilitate all of the logistics because there's a whole bunch of little questions that come up after, like, what do I need from the funeral home? What do I need after? Do I need to ask for different documents for certain things? And so I think an experienced death doula can really provide a lot of value. However, again, the caveat is that there's no real standardization in that process. So I have seen it be very beneficial, but some reservations also.
Okay, thank you so much. So that actually concludes the totality of our interview portion for today's session. We did receive quite a lot of questions through registration. So audience members, thank you so much for submitting those and also for submitting questions throughout the session. So we're going to go ahead and move on to audience Q&A. And for these questions, Adam, Dawn, feel free to sort of jump in as you feel appropriate and let me know if there's anything I missed and you'd like to touch base on. So we'll start with our first audience question, who asks, can you refuse invasive treatments and instead request medical assistance in dying?
Well, that's an easy one. So let me take that one.
Yeah.
Yes, absolutely. You can. I mean, first of all, you can refuse any medical treatment that you want if you have the ability to make decisions for yourself. In fact, there's been new guidance published on this for MAID assessors and providers just in the last year. Your assessors will want to consider very carefully why you made that decision. But unless something is seriously amiss, then absolutely you can choose not to go ahead with something that would be disagreeable and instead conclude that your time has come.
Okay, thank you so much. Next question. This audience member asks, can you discuss the availability or access to medical assistance in dying in rural or remote areas of the province, such as, and they give the example of the Gulf Islands. Either of you can speak to sort of access in general for rural, remote communities, but then as well as, what access looks like for in your communities.
I can start. I
Yeah.
think it's certainly limited in rural areas. So I'm pretty urban in Victoria, which may still be the MAID capital of the world. And so there is a lot of accessibility here. There's not really an issue. However, I do travel upwards of 3 hours sometimes to the middle of the
Wow.
island just because it can be very difficult. As I mentioned, I also do a lot of the patients that come up on the Gulf Islands. It's kind of a silver lining it's been a nice way for me to see different areas of the Gulf Islands that I wouldn't otherwise get to go and visit. However, it is more cumbersome. It's an entire day to do a case like that. And it is in smaller communities, there is a different social context, like a lot of people know each other. And so depending on how progressive that community is, that can influence that. I know Adam works in a more rural area than I, and so may have a different perspective too.
Yeah, I mean, I can come in a bit. The shortage of healthcare providers across the province, across the board, it's generally worse in rural areas. As far as I know, all of the health authorities in BC have programs to try and ensure that the needs of people living remotely are met. It's funny the question I asked about the Gulf Islands because I'm joining from and live on one of the Gulf Islands. I mean, I think my advice to someone contemplating MAID would be to get in touch with, unless you've already got people lined up who can do it for you, and you know your own primary care provider, your own nurse practitioner or GP can be one of the two assessors and can provide MAID for you if they are willing. But if you haven't got people in mind already and agreeing to do it, then I would be getting in touch with your health authority's assisted dying program or MAID program as early as possible so that the arrangements can be made. Um, it is it is, of course, well, it is possible for assessments to be done via telehealth in many circumstances. So you can, you know, the assessments can potentially be done over a Zoom call. But obviously the provision, you know, I like to think I've got good communication skills, but I'm not able to end someone's life over over a Zoom call. So that needs to be in person, and it can involve a lot of traveling. And I have had to do that on occasion for people who live remotely.
Yeah. Absolutely. All right. Thank you. Next question. This audience member shares that unfortunately they have stage 4 metastasized cancer. And their question is, how far in advance can you be assessed for MAID?
Okay, I'm going to take all the easy ones here, I think. I mean, again, that's that so there is no, once you have been found eligible for MAID, it does not expire. Um, and I mean, you know, I'm sorry to hear about to this question. I'm sorry to hear about what it is that you are facing. What a thing to be facing. Um, if you are considering MAID, and to the extent that you're joining a webinar on it, I would get moving now. You have nothing to lose, and by doing it early, and you don't want to leave it too late. If you have metastatic cancer, if your natural death is reasonably foreseeable, then I would get going with this as soon as you can, so that things are set up for you. And then, of course, there is no pressure for you to have MAID within any time period, or even to have MAID at all. If circumstances change and you decide not to go ahead, then there is no obligation. If you have been assessed and found eligible for MAID, there is, of course, no obligation. You can change your mind at any time.
Okay. Thank you so much. All right, next question. This audience member asks, how would you conduct a MAID assessment with somebody that has a disability? So for example, somebody who is deaf or sight impaired. This is not a disability, but also somebody, for example, that might have a language barrier, that sort of thing. Anybody like to jump in first?
I think use the tools that we have available to us. Certainly speaking a different language isn't a disability, but that's something that I would definitely be using a professional translating service for, instead of communicating through families, which is pretty helpful in most other areas of healthcare where that can be reasonable. But we want to make sure that that request and understanding is voluntary. I find speech language pathology for people with communication difficulties can be really helpful. They have all kinds of tools like gaze tracking technology in that for communicating with people with advanced neuromuscular diseases. So I think, yeah, use the tools that are available to you. And if you don't know of any for your specific context, ask the coordination service or ask colleagues, because I think that there are lots of great tools that can be really helpful in those circumstances.
Yeah. Adam, same question for you.
I mean, exactly what Don says. The thing that I'd add, which almost goes without saying, is that is that communicating with people who have difficulties communicating, or overcoming sensory disabilities or other problems. This is kind of pretty fundamental to the responsibilities of any healthcare provider, and certainly anyone carrying out a MAID assessment. We do this all the time. I do this all the time in my work as a GP, and as an emergency doctor, an emergency medicine doctor. So figuring out and deploying the resources which are available to us, which thankfully in a publicly funded healthcare system like that of BC, there is quite a lot that is available to us. The challenge usually is, or it's not the challenge, but it's important to acknowledge that it takes time. If you're communicating in a language, through a professional interpreter in a language you don't speak, or with someone who has communication difficulties, then it's going to take a fair bit longer if you do it properly. And I think, those of us carrying out MAID assessments, because of the weight of what it is that we're doing, are determined to do it properly, and we will. But communicating with people who have difficulties communicating, that's an everyday responsibility, and anyone providing healthcare ought to be well equipped to do that.
Yeah, well said.
I
All
have
right.
another add-on, actually.
Yeah,
So
go
Adam
ahead, Don.
mentioned time. That's actually very important to mention. So as a patient or provider, make sure you give yourself enough time. Another situation in which I encounter that is people with dementia. I assess a fair number of people with dementia because I find they may be there's like a list that comes out that's triaged of people who have requested. And I find that can be a more difficult evaluation. So make sure you give yourself enough time. This isn't a one item per 15-minute thing. Sometimes I do 2-hour visits for a person with dementia, just because we need to be certain that we're getting accurate information, that there is a thorough understanding of what they're asking for. So that timepiece is really critical.
All right, thank you both. Next question. This audience member asks, are the laws and regulations that govern MAID specific to a region in BC, or are they province-wide?
They're actually countrywide. So the law that governs MAID is set out in the Criminal Code of Canada. One of the things that makes me ever so slightly uneasy about this work is that the criteria that I'm applying are set out as a defense to the offense of homicide. In other words, I have to get this right, otherwise I risk being prosecuted for a very serious criminal offense. There are then regulations that are also federal. Bad question to ask an ex-lawyer. And then the provinces have a certain amount of discretion in how they so it's oversight is carried out at a provincial level. In BC, oversight is carried out by the MAID Oversight Unit, which is part of the Ministry of Health. I should declare an interest here. I'm currently one of their medical advisors. So the paperwork that's used in BC and the reporting mechanisms and the way in which you're checked up on is provincial. And then the professional colleges, so the regulator of physicians in my case, of nurses in Don's case, they also have a role in that. But the basic legal framework is federal, national, and set out in the Criminal Code of Canada.
All right, thank you. Don, anything to add just before we move on?
I'm not super well informed, but I am aware Quebec does have a lot of exceptions to rules. And so I won't really speak to that, except to say that there are some nuances with Quebec. But if you're a resident of Quebec, I would speak to an assessor in Quebec who's really informed about those differences.
Yeah.
And I should just say that is an important qualification to what I said. What I said applies to Canada, except for Quebec. There is a different framework in Quebec.
All right. Thank you both. Next question. This audience member is curious about demographics. They ask, what is the age range for people that receive MAID in British Columbia? I'm not sure if you have those data points just at the tip of your fingers, but
I actually happen to have them at the tip of my screen, or my second
there you
screen, so
go.
I can answer that right now. So in 2023 is the most recent data that's been published. 2,767 people in BC received MAID in 2023, which is about 6% of all deaths occurring in BC in 2023. The average age was 78 for women, 77 for men. So this is mostly elderly people. Ranging in it. So MAID is not lawful in Canada at the moment for people under the age of 18. You might want to ask yourself whether someone under the age of 18 who's dying a horrible death from some awful form of cancer should be denied the right to MAID, and that's not a question for me. But anyway, that's how the law is at the moment. The large majority of deaths from MAID occur in people aged over 65. The largest age group is patients, well, you can kind of tell from the data, from the ages that I just gave you, patients aged between 76 and 80. And then we got lots, it's mainly but not exclusively people with cancer. After that come cardiovascular conditions and neurological conditions. And the data is, if you're interested, just Google MAID data Canada, and it's all there for you.
All right. Thank you so much. And thanks to that audience member for the question. Let's go ahead and move on here. So, we already spoke, Don, you spoke a little bit about how quite a few of the patients that you speak with are experiencing some form of dementia. So this audience member is asking, if I receive a diagnosis for dementia, how difficult is it to access medical assistance in dying? Can somebody with dementia access MAID?
Yes. Provided they have capacity. And so they can communicate, understand, appreciate their diagnosis and consequences, and talk to you about their reasoning as to how they came to that decision. And so in most cases, yes, if someone can't demonstrate capacity in those 4 areas, then it is not possible. However, capacity is variable. And so sometimes, urinary tract infections tend to be a good example. People may have dementia, but be very capable in their day-to-day lives, develop an infection, and they see bugs coming out of the ceiling and are suspicious of their families. And so there are some situations in which people lose capacity, like someone experiencing delirium. However, that is usually reversible. And so it all depends on that person's individual context and their ability to make decisions.
Yeah, absolutely. As a follow-up question, how is capacity assessed in the context of MAID? So if somebody, for example, has a dementia diagnosis, perhaps they're not quite at a moderate or severe stage yet, but is wondering, how bad does it need to get before I could contact someone? If it gets too bad, am I stuck without MAID? What advice could you give to someone?
I would say early to moderate stages is the time to start exploring that as an option, because there will be a day in most dementias, people who die with dementia, there will usually be a day where that capacity is lost, and it's pretty impossible to predict when that could happen. And so I would say certainly start a little sooner, or at least start asking, because that can be quite helpful. And how do we kind of assess capacity in those 4 domains? So communication, understanding, appreciation, and reasoning. And so that's kind of the framework I use when I see and talk to a patient with dementia. I think there is a large desire for advanced directives in patients with dementia. I hear a lot from people who tell me, when I need to go into long-term care, I want MAID. And that's unfortunately not how it works. Unless you use a waiver, but that all needs to be set up well in advance. And we might see that change, but we'll have to wait and see. Quebec is dipping their toes into that a little bit, and so it will be interesting to see how they manage and work with those changes.
Yeah, absolutely. Adam, anything to add before we move on?
Yeah, this is such a big question, and is the problem with MAID law as it exists in Canada at the moment, or the rest of Canada outside of Quebec. The challenge here is that with with the progression of dementia, so people's capacity to make decisions for themselves declines. And also suffering declines. And one of the eligibility criteria for MAID is that you are suffering intolerably in a way that can't be relieved in a way that's acceptable to you. And so people often, the sort of the classic situation is that someone approaches you, fairly early on following their dementia diagnosis, and as Don says, almost always what they're saying is, once I'm no longer able to look after myself, once I can't continue to live at home independently, that's when I'm going to want MAID. They're not ready for it now. And the difficulty is that as their illness, as their dementia progresses, there comes a point where they are no longer able to say with legal capacity, I now want MAID and I understand what it is that I'm doing. And there's a kind of workaround for this, which is a bit of law called a waiver of final consent, which is really designed for people who have a date in mind when they want to have MAID, and they want to protect themselves against the possibility that they lose capacity before that date. And you can use those in dementia, and you can set a date, and if the patient gets to that date and isn't ready to have MAID, then that's fine. You create a fresh one of those. They're not designed to be used years hence. You can't put a kind of backstop date of 10 years, 10 years on as the date when you want to have MAID, because that's clearly not the purpose of the law. So they're a very unsatisfactory way of protecting people who are determined not to go into residential care settings. And would wish to have MAID once they had lost the capacity, lost the ability to make decisions for themselves. They're not a satisfactory way of dealing with that. They are helpful for dealing with it, but there is currently a consultation being done by the federal government, however long it lasts for, which anyone who's interested in this may want to Google and fill in, about what Don was mentioning, advanced directives, so that people can more precisely say, this is what I want. These are the circumstances in which I want to have MAID. But it is tricky. So I think what I would echo what Don says, which is get in touch early, have these conversations with anyone who may be involved in assessing or providing MAID for you, and be aware that the law is a little bit problematic in this situation. The other thing I would say, and I'm sorry to bang on about this, but I guess this is, so many people are asking these questions so many times, is do be aware that typically as dementia progresses, your suffering declines. And this isn't often what people want to hear. But you today, if you have a diagnosis of early dementia, may find the idea of the progression of dementia and being dependent on others absolutely horrifying. Anyone who's looked after a lot of elderly people in their careers, and especially people with dementia, will be able to tell you that, the point at which none of us want to get to is often also the point at which you're not really so aware of what's going on. And in fact, your horror at that situation, that's a horror that current you experiences. It is not a horror that later you experiences. This, I'm not at all arguing against MAID being available for people in those circumstances. I'm just saying, do be aware that suffering does decline, and it may be more horrifying to those around you than it is to you in the later stages of dementia.
All right. Thank you both so much for that. We have just a few minutes left, so we'll tackle just a few more questions. This audience member asks, how could someone speak with staff in an acute care or a hospital setting, for example, about some of the cultural or religious practices they'd like to honor for, let's say, a dying loved one that's going to, perhaps against their choice, die in hospital? And so how could, a loved one sort of try to facilitate a bit more ceremony or practices into that death experience?
I can take a swing to begin with.
Yeah.
I mean, many larger hospital sites have a spiritual care program. And so that is one avenue. And to access them or to get in touch with them, you could ask pretty much any nurse or physician involved in your care. They'd be able to kind of help you navigate a bit. That's kind of my go-to response. Adam, anything to add there?
Yeah, I mean, you should be asked is the answer to that question. You
Yeah.
should be asked. You shouldn't have to raise it yourself. And if you are not asked, then speak up, at the earliest opportunity and say, look, this is going to be really important for my loved one or for me or for us. And this is what we need to do. And if that is not accommodated to the best abilities of the setting where you find yourself, then something is going wrong. I working with an on reserve Indigenous population, I hear endless stories of people heading off to big city hospitals where their cultural needs are not adequately taken account of. So I have to acknowledge that it is, that people don't always get these things right. But I hope that most of the time people do get them right. Please speak up. And if you do not feel that requests are met with sensitivity, then something has gone a bit wrong. And it would be the situation in which diplomatically it seems to me to speak to someone with the authority to put them right, because this is so terribly important.
Mhm. Absolutely. All right. Thank you for that. Next question. Let's see here. This audience member asks, what specific challenges have you experienced, if any, with assessing Track 2 requesters? I'm not sure if either of you have assessed or provided for Track 2, but nevertheless, anybody who wishes to jump in.
I mean, I can speak briefly. I could do a whole, hour and a quarter webinar on this, at some point. So for those who aren't familiar with the lingo, Track 2 means people whose natural death is not reasonably foreseeable. In other words, people who have probably significant disabilities, but that aren't going to kill them. These were not eligible for MAID when MAID first became legal in Canada, but for a number of years have been eligible for MAID. The law puts in place a number of safeguards, including that the assessment must last for at least 90 days, and various other safeguards as well. I read out some statistics a few minutes ago, suggesting that MAID is predominantly older people with cancer, and that's absolutely right. Track 2 cases tend to be younger people with chronic disabilities that people have lived with for many years, and typically have reached the point where they just can't go on any longer. They've tried so many things, and life has been so wretched. And of course, people who have had long experiences like that often are suffering from associated mental health difficulties, and all sorts of challenges in their day-to-day life and relationships with other people, and relationships with the world. So these are heartbreaking cases that are agonizingly difficult for MAID assessors and providers to do, and I think it would be right to recognize that there are a lot of there's a number of people involved in MAID who just find these cases too hard, or some of these cases too hard to do. I do them because I think that anyone who is legally eligible to MAID ought to have access to that. But when I was talking earlier about sometimes losing sleep over difficult MAID cases, these are the ones that I was talking about. They are hard. They take an enormous amount of time and a personal emotional toll. And I guess when I was talking earlier about being pleased sometimes when the outcome of an assessment is that my patient decides that maybe there are other things that they would like to try before they want to go ahead with MAID. It's in Track 2 cases where that sometimes happens and feels like a good outcome. But I think we also need to accept that sometimes it is a good outcome when people get what it is that they themselves are best able to determine is what they really need, which is to draw a conclusion to a painful life in the manner and at the time that they choose.
Absolutely. Thank you for sharing. Dawn, same thing for you. I'm not sure if you work with track two patients or assess or provide, but same question for you.
I do, not a ton. I tend to take many people with dementia rather than track two, because it's a little bit gray as well. There's fortunately some guidance documents now that support pretty much all dementias being on somewhere on a trajectory towards death. And so that guidance document is helpful in supporting our decision making about it. I think it's very, very contextual. I think in the track two patients that I have seen and assessed and provided for, sometimes in my head, am thinking, I'm not sure if I think that would be intolerable suffering for me. But I try not to let my own bias influence my clinical decision making and following the law. And so that kind of trumps, lack of a better word, lacks it makes it more complicated. And again, there is the situation in which you can lose sleep. And I've done some cases and worked with people younger than myself, and those are really difficult, especially if they probably have a good 20, or maybe not good to them, if they have about 20 years left. It's very nuanced, but I don't think we have time to get into the depths of that question. So that can be my 30-second answer.
Thank you. And, just as Adam said, track two in and of itself could be an hour, 2 hour long seminar by itself. It's just as, complex and nuanced as other parts of assisted death. But thank you both so much for your time today. We are out of time for our webinar. I want to thank everybody on our panel for joining us today, for our audience members for submitting those wonderful questions, and for giving us your time. I will bring up that next Thursday, February 6th, we will be commemorating the 10-year anniversary of the decision made in Carter versus Canada, on our webinar with Jocelyn Downey, which will be, that's right, February 6th, next week, Thursday at 3 p.m. Eastern. So if you haven't registered, please go ahead and check out our website link. Dawn, Adam, thanks again so much for your time, for your insights. We really appreciate your participation here today.
Yes,
Thanks so much
for
for having us.
Yeah. All right, everybody. That is it for today. I hope you all have a pleasant and wonderful afternoon. And as a reminder, this session will be recorded, so stay tuned for our follow-up email. All right. Thanks, everyone, and have a good day.
Bye-bye.
Bye.